Thank you very much. It's been a really nice session covering all the important points. These are my financial disclosures. I run 2 myopia clinical trials. The money goes to the department, not to me. So I don't really have a conflict of interest. You know, when I was asked to talk about the future of myopia management, it occurred to me that really we're going back to the future. I hope most of you understand Punjabi. When I was young, my mother used to say, "Oh, anak la de, akhan kamzor ho janiyan." She said, "Take your glasses off, your eyes will become weak." And it is these very glasses that we've been shown actually make you more myopic because they cause peripheral defocus. She used to say, "Ki bahar jaake khed, andar rehna hai." She said, "Go and play outside, don't stay inside all the time." So everything that we have proven epidemiologically now, actually, all our mothers and our grandmothers knew. So the question is why? And so what I want to do is I want to talk to you about the future. And the future depends on us advocating for children at government level. Public health policy is going to be the most important thing that turns around myopia management. And I'm going to show you why that's the case. This is an editorial that I was asked to write for I. If you get a chance to read it, it's probably the only editorial I've ever written that I've talked about, because it puts together all the information that proves to you and your patient's parents why behavioral intervention is so important. Let's start with this. Study in China, I think it was Shanghai, they have this thing called WeChat, right? And they randomized parents into 2 groups. On a Friday, one group got WeChat messages: remember to let your children play outside, don't let them use the digital devices, make sure if they use it, they take a break for at least 10 minutes. And they had the group that got no messages. Well, over a 2-year period, including part of the lockdown, there was a significant decrease in the mean myopic shift in the group that got the WeChat message on a Friday night. Okay? Just a WeChat message. So how many of you, when your patients are coming, send a message, "Don't forget you have an appointment tomorrow," right? Well, why can't we send a message to our parents who are getting myopia treatment for their children? Please remember to go outside and play. Please restrict your digital devices. It's a simple thing, right? Okay, this is really interesting. Increased time outdoors is followed by reversal of the long-term trend to reduced visual acuity in Taiwan primary school students. From 2001 to 2011, the prevalence of reduced visual acuity due to myopia increased from 34.8% to 50%. After the implementation of the Tian 120 outdoor program, the prevalence decreased continuously from 49.4% to 46.1%. Now, if somebody showed you that atropine glasses dropped the risk by 3% of visual decrease due to myopia, you'd say, fabulous intervention. This is a simple, free, nothing in life is free except this, free advice. The Singapore Health School Service took up the mandate of the National Myopia Prevention Program, and it began in 2002, right? Based at school level. So the teachers are telling the children, you have to play outside. You have to sit by a window. You can't read. And this is what they found. When you look at the analysis between 2004 and 2015, between 2 types of children, primary school and secondary school, the amount of myopia dropped more in the primary school children than the secondary school children. So what I've been saying, intervention earlier is better. Here is absolute evidence that simple public health policy changes. It changes the outcomes of myopia. So why in India are we not speaking to our education ministers, our health ministers, and saying, listen, not only will we improve their overall health by going outside and playing more, they will improve the rates of myopia. Now, people are very taken by the lamp studies, right? In Hong Kong, the Chinese government did not institute any public health policy till 2019. The lamp studies were started before then. I guarantee you, as they look at the lamp study follow-up now, their results will get better and better because the public health policy was instigated in 2019. So, 2 hours daylight exposure, and it doesn't matter if they already got myopia. People are saying, well, it's better before they get myopia. Not true. Australian studies, Taiwanese studies have shown even if the myopia started, doing the 2-hour daylight exposure is still effective. Do not let them read in dim light. I'm not sure it was Dr. Jatani's study or Dr. Guattari's that showed if children read in dim light, it drives axial myopia. And there's an animal model, the macaque neonatal monkey, in 1978. How many people were not born in 1978? How many people were not born in 1978? It's most of the audience. In 1978, they reared macaque monkeys in monochromic light. That is the equivalent of reading in dim light. And they got axial myopia. And the other thing is, after sustained near work for 30 minutes, and Pei Chu's work from Taiwan is brilliant, take a 5-minute break. Okay. And how do we measure myopia, right? This is going to be very quick. How many of you have growth charts? If you're a pediatrician, we have head circumference, we have weight, right? Then why on earth are we not using the normal axial growth charts? These are all the ones that are available in the literature: white population, male, female, Asian population. That's not Indian, Asian population. These are the different studies. They're all at the bottom that show you the normal growth. African American, Hispanic, Native American. What we want to see is we want to see the green line. We don't want to see the red line at the top. If a child is going steeper than the normal curve for that child's ethnicity, then we're not controlling them. We want them to go parallel. When people say 0.5 diopters per year, well, actually, it depends on the age and the ethnicity, because it might be 0.75. It might be 0.25. So we need growth charts, axial growth charts. These are the ones that I have put together with my fellows from the literature, and we're hoping to make them openly available. But they're very easy to make. And we need to standardize the myopia measurement. So therapy, in the last minute, look, these are all the things that we do in our clinic, right? The myopia. If your myopia is greater than your age, before you start any treatment, please investigate. If a 3-year-old is -5, make sure they don't have a connective tissue disorder. Make sure they don't have nyctalopia. Make sure their retina is okay. Because I don't know what atropine does to a defective retina. Does anybody in this audience? Are you willing to take the chance? Or at least tell the parents, we don't know if this is going to do any damage, right? We don't know if the glasses are going to work. And then, if both parents are myopic, always behavioral intervention, and then I do the pre-myopia treatment. The atropine's fine, 0.01. I have never had to use 0.05% atropine because the behavioral intervention, we make the parents agree that they're going to do this. And if they don't do it, we say go somewhere else. Okay? Now, the role of light therapies is very controversial. Red light therapy is controversial. However, when you look at the studies, it works. It's controversial because there's been one case report of retinal damage, but it turned out that that child already had a retinal problem. So your case choice matters as to what you can do. Blue light therapy is coming. And blue light therapy is the equivalent, 10 minutes of blue light is the equivalent of 2 hours daylight exposure. That's what they're saying. They haven't proved it yet, but the early studies showed that that is happening. And there are newer non-atropine drops that are being developed. But here's the turning point Siddharth already talked about. Two major developments in myopia in 2013. Two separate groups independently found the same loci. 23andMe and the CREAM Consortium. And they're all connected. So this is what I believe. Behavioral intervention at a public health policy level delivered in schools is essential. Standardized myopia progression measurement. Let's not talk about 0.5 or 2% or 0.2% growth change. Let's look at the chart for the ethnicity and the age and see what's happening. There's a cascade of treatment algorithm, and combination is very important. I think even orthokeratology in the right place, in the right hands works. And in the USA, I have a large number who are treated by my optometrists. I'm not saying it's the right thing in India. I'm saying that in certain places, it's an option. And the molecular evaluation for non-responder loci, as Siddharth said at the very beginning, is going to be the key. Thank you very much.
Thank you, Ken, for highlighting such an important aspect of myopia management. The fact remains that over the past 50 years, there has been no significant change in the genetic makeup of any of the race in the world. However, all races across the world are showing an increase in the myopic prevalence rates. There is no doubt that, of course, there is variability, possibly again based on the environmental differences that are there, the behavioral, the cultural differences that different races have. But there is no doubt that it's environmental, particularly the visual environment of a child, of a growing child, that has made the maximum impact on the increasing prevalence. And something I would always say that just like you never treat diabetes without curtailing sugar and carbohydrate intake, you cannot think of treating myopia without attacking the very basic reason why children are becoming myope, which is the most constrained and narrow visual environment that they are in. And as Ken pointed out, it's those behavioral modifications that are extremely key for the success. Maybe the variability that we are seeing in results of any intervention may be there because of the fact that in some cases, some children just become aware of this, or the parents become aware, and they bring about behavioral change, something that we must measure for all our interventions and assessing the impact of all our interventions.
I would go a bit further. This is what I agree with everything you've said. If you read a paper about myopia, and in that paper they do not talk about behavioral intervention at all, don't read it. Because the minute you start doing that, and you say, we're not going to read your paper because there's nothing about behavioral intervention, people will start changing their behavior. All the companies will make sure that behavioral intervention is the default. You have the power. If we say we're not reading your paper because it says nothing about behavioral, look in the LAMP studies. Read that and see if it says anything about behavioral intervention. It doesn't. In the Singapore study, the ATOM studies, it doesn't. But in Singapore, they didn't do it because they said already they had public health policies in place from 2002. The ATOM study started in 2004. So it's really important that we stop reading papers that are misleading. And if they say we did it, then they need to publish an addendum to the paper, say that actually our methodology is incorrect. We did tell them about behavioral interventions, and this is what we said. Because there's too much literature about myopia that is too confusing. The PDIG study that said atropine makes no difference. In the United States, children, they know their digital devices better than they know their parents. And they didn't tell them to stop any of their behavior or change it. So throw that paper out. And Mike Repke is very upset with me because I keep saying that in front of him. But he understands that behavioral intervention is so important.